a 33-year-old man presenting with spontaneous tinnitus and nausea. Which one of the following is most likely based on the imaging shown? Yes. I need some responses. So what do we see here? First, tell me what is the sequence of MRI which we are seeing. We'll try to take a separate session on how to, what are the various sequences in the MRI, how to identify each sequences. So what we see here is a T2 axial sequence. So this is the lesion which we are describing here. So what is the probable diagnosis? What is the probable diagnosis? Yes. Okay, so what we see here is whether it is an arteriovenous malformation or a cavernous angioma, or is it a bleed? Okay, so let us discuss about cavernous angioma. So these are mulberry-like lesions consisting of vascular spaces with little intervening tissue and hemorrhage of different ages. The incidence of clinically symptomatic hemorrhages remains uncertain, but is less frequent than with the cerebral AVMs or dural fistulas. A previously bled or infra and infratentorial location, they are the main prognostic factors for the recurrent hemorrhages. A previously bled lesion or an infratentorial lesion are important prognostic factors for recurrent hemorrhages. So when the lesions lie close to the cerebral cortex, they may produce epilepsies. They are occasionally intraventricular or arise on a cranial nerve. So in the imaging, what we see is an well-defined dense or calcified lesions in CT, which may show patchy contrast enhancement. On MRI, they appear multilobular with mixed but predominantly elevated T2 signal intensity, centrally surrounded by a halo that is called as the dark hemosiderin rim. Okay, so then the susceptibility sequences are the most sensitive, where we can see areas of blooming. They can be multiple, especially in the familial cases, and in some cases, it can still be an incidental finding. So this is a typical picture of a cavernous angiomas. So this is another clinical scenario. So this is a 49-year-old man attends the emergency department complaining of headache and vomiting for the last 2 days. And now he has clumsiness of his left hand. There is no history of trauma. His GCS is 15/15. CT shows there is a right-sided subdural, acute subdural hematoma with midline shift of 5 mm. Which one of the following would you perform next? So we have a CT plane, which is showing an right-sided acute SDH with a midline shift of 5 mm, which is spontaneous. There is no history of trauma. So what is your next line of investigation? Yes. What is your next line of investigation? Okay. So it is D. MRI head with diffusion weighted sequences. Okay. So any other guesses? Okay. So what you need to, so to put this question in another format, which aneurysm produces an acute SDH? So there are certain, usually commonly the aneurysms present with subarachnoid hemorrhages. Aneurysms, when they rupture, they present with subarachnoid hemorrhages. There are certain aneurysms which present with intracerebral hemorrhages. Like you can get an temporal ICH in an inferiorly projecting middle cerebral artery aneurysm. You can get an flame-shaped hemorrhages in the frontal lobe in case of anterior communicating artery aneurysms. So what aneurysmal ruptures produces an acute SDH? So that is the answer for this question. Can you tell me? So that is not in the option. what aneurysmal rupture presents with, can present with acute subdural hematoma in addition to subarachnoid hemorrhages. Yes. So there are only some 4 or 5 vessels to present with acute SDH. So it's going to be either anterior communicating artery or anterior cerebral artery or middle cerebral artery or internal carotid artery, ophthalmic arteries, posterior communicating arteries. No guesses? Okay. I see. Okay. Okay. So I'll tell you. So the posterior communicating arteries they have chances when the aneurysm ruptures, there are chances of development of acute SDH. Okay. So when you have a spontaneous SDH, always remember that we need to go ahead with an angiogram. So that is most important thing. So the arise of the causes for spontaneous SDH are commonly, first thing which we need to be ruled out is an aneurysmal rupture. One is the commonest one is the posterior communicating artery. And the other thing which we can have in an acute SDH is an AVM, is another common cause for spontaneous acute SDH, and dural AV fistulas. So these are common presentations of spontaneous acute SDH. So remember the posterior communicating artery aneurysmal rupture, the dural AV fistulas, and sometimes the AVMs. So once I had a patient who's a 15-year-old female. So some 3 years ago, a 15-year-old female, when she was attending class in the school, suddenly she became unconscious. So she was brought to the ER where I worked, and they have checked all the electrolytes, everything. It was all normal. And then the CT was taken, which showed an acute SDH with a midline shift of almost 15 millimeter. So there was no history of trauma. There was no history of trauma, but still there was an acute SDH. So immediately, in view of the emergency, in view of the anisocoria, immediately shifted to the theater without doing any angiogram because of the acute emergency. So did a decompression and a very cautious SDH evacuation. So when it was done, then a huge frontotemporal AVM was noted. It was a huge frontotemporal AVM. So probably a Spätzle Martlin grade 3. So then after the patient then revived back, the patient presented to us only M2. Then the patient revived the GCS, the anisocoria is rectified. And then when the GCS improved to almost 15, then the DSAs and all the further investigations was done. And then the second surgery on AVM was accomplished. So the we need to always keep in mind of all the causes whenever we see such kind of cases. So common things is always common as far as the specialty is concerned. But as far as neurosurgery is concerned, the uncommon things is always is common for us. Okay. So always keep in mind a spontaneous acute SDH. The commonest cause is posterior communicating artery aneurysmal rupture, the dural AV fistula, and then AVM.